Very warm welcome to all of you, guests and participants. Welcome to First Check's webinar titled From Awareness to Action, India's TB Elimination Roadmap, marking World TB Day tomorrow on March 24th. First Check, under Data Lead's an authorized signatory, which has been a pioneer in fact-checking. Today, we are trying to evolve this into a dynamic platform, hosting critical dialogues on public health challenges. Our distinguished speakers today will debunk persistent TB myths, highlight India's progress alongside remaining challenges and gaps towards our 2030 elimination goals, and also interestingly, talk about the role AI innovations will play in transforming TB diagnosis, treatment, and management. Thank you once again for joining us. With that, I would also now request Dr. Saud, co-founder of Data Leads and director of First Check, to highlight why there is a need to have dialogue for India's TB elimination goals. Over to you, Dr. Sabha.
Yeah, thank you so much, Urvashi, and good afternoon, everyone, and a very warm welcome to all of you. Tuberculosis continues to be one of the most pressing public health challenges in India. While we have made meaningful progress over the years with improved diagnostics, better access to the treatment, and a strong policy commitment, the journey towards elimination is still ongoing and demands sustained and collective effort. I'm Dr. Sabah Mahmood, co-founder of First Check, and it's my privilege to welcome you all to today's special webinar on India's TB elimination roadmap. At First Check, we work at the intersection of public health and information integrity, addressing the growing challenge of health misinformation, which often leads to delay in diagnosis, disrupt the treatment, erodes trust in healthcare institutions, and ultimately costs lives. We monitor misinformation vectors related to various health conditions, including TB, which is not just a medical issue, but is deeply connected to awareness, stigma, and access to accurate and timely information. This webinar is part of our ongoing commitment at First Check to foster informed conversations and meaningful collaborations to ensure that accurate information is accessible to all. From First Check's perspective, our call to action is clear that we actively challenge misinformation and amplify the verified and evidence-based health information. Each of us here can be a force multiplier in this effort by asking questions, sharing information responsibly, and supporting the credible voices. Today, we are honored to have an esteemed panel of speakers who bring deep expertise and valuable perspectives to this conversation. Thank you once again for joining us today, and we look forward to a meaningful and insightful discussion. I now hand it over to my colleague Sakshi, who will give you a brief introduction of First Check. Thank you so much for joining.
Thank you, Dr. Sabha. As a child, I remember sitting with my mom and watching this so-called Acharya on television. And the next day, my mom would be making these so-called work. Continue to receive such videos on social media platforms.
Sakshi? Sakshi, you're on mute.
I'd like you to get through what is First Check and what we do at First Check. So the idea of First Check dates back to 2015 when Data Leads organized a boot camp in Srinagar.
Just give us a minute, please. Thank you.
Hello, can you hear me? Hello?
Yes, Sakshi, we can hear you.
Arushi, can you hear me? Because she said she's not able to.
No, we can hear you, Sakshi. Please go ahead.
You can? Were you able to, ma'am, from the starting?
Yes.
Oh, I think they have a problem.
Yeah, please go ahead, Sakshi.
Okay. I'm sorry for the technical glitch. I think you all are able to hear me now.
Yes.
Yeah. So I was at that how the idea of first check came. So it dates back to 2015 when Data Leads organized a boot camp in Srinagar, bringing together all the doctors and journalists across India. This sparked the thought that what if we collaborate these experts and make the people get informed about the health misinformation out there. So in 2019, First Check came into being. We have received several national and global recognitions as well, including the Global Fact Check Funds Built Award by the IFCN, etc. Can we move on to the next slide? Okay, that's totally fine. So, what is what is the vision of ours at First Check? What we do, we debunk the fact. Oh, okay, so the slide is here. So we present the health information that is evidence-based, unbiased, and credible, and we ensure that it is accurate. What we do, we also simplify the complex medical information and bring clarity to the people. And we also debunk the health information claims across social media platforms. And here we don't want to reject technology, we want to use it responsibly. So we also inform the people about how we use AI in medical healthcare as well. This is how we do the fact check. So the step one is how we select the videos. What we do, we get queries on our WhatsApp tip line. We select the videos from there. People send their queries across social media platforms as well. And these videos gain millions of views. So the second step, we put the entire transcription of the video exactly. So the transparency is also there. Then come the research part, where we find studies which are also old and new studies. Then we talk to the expert or the public health expert or the doctors respective, respectively, and then we debunk the claim. Then we provide the fact, which is after we get the studies and the expert talk. Along with the fact checks, we also have ground reports. On to the next slide, please. Okay, so we have done ground reports in the form of multimedia stories, video stories, photo stories, etc. So we have done stories on schizophrenia from cancer survivors, on gig workers, on ASHA workers, and many other stories as such. Then we also have a wide network of doctors and public media experts across India. And we also organize webinars like this and the Health of India Summit. We had 4 events as such. And then in the future also, we want to continue on the same. And at the end, I would only want to say this, that we are open for pitches, and even doctors and public health experts can contribute to our website. And you can get all the details on the website. And also that webinar like this is important to tackle misinformation in India. Thank you. On to Uvashi.
Thank you, Sakshi and Dr. Sabha. Uh, I believe we are still waiting for Dr. Soumya to join in. She's just going to take another 2 to 3 minutes. But let me just move on and introduce Dr. Jain, Dr. Garima Jain instead. We will wait for to hear from Dr. Soumya. I will go to the next speaker and introduce Dr. Garima Jain. She's a scientist with National Institute for Research in Digital Health and Data Science, ICMR. Her deep expertise lies in digital health, AI-driven diagnostics, and computational pathology. Over to you, Dr. Jain.
Hi, good afternoon, everyone. Thanks so much, Urvashi, for that kind introduction. So it's a wonderful initiative by all of you to create awareness and bring together so many experts together to talk on such an important topic today. I'll be mainly talking about, can I share my screen? Am I audible, I hope?
Yes, you're audible. You can share the screen, ma'am.
Yeah. So since I had a slot of 10 minutes only, I've tried to keep it short. So I'll be talking about advancements in TB research, diagnosis, and treatment. My area of expertise is digital health. So I'll be talking about the latest innovations which are required, and what are the lacunae, why are these innovations not being implemented into the INTP program, how many of them are being implemented, what are the bottlenecks, and the way forward. So beginning with, firstly, I would like to say that TB elimination will not only require better treatment access, but also earlier detection, faster triage, and stronger data scalable systems and digital innovations which are scalable. At present, a lot of bright minds throughout the country in the private sector as well as in the technical institutes like IITs and IITs are coming with great solutions which can actually solve the TB problem. But the thing is that many of them are not scalable, right? So the solution, that digital health solution that has to be made, has to be something which can be integrated into the existing program, and health technology assessment and cost efficiency analysis of each solution has to be done. So these are two bottlenecks which we have encountered when digital health solutions for TB come to us for evaluation. So TB is a major challenges after so many years of trying to eliminate TB from our country. TB still is a major challenge because there is a diagnosis is often delayed in TB. So patients remain infectious for a long period of time, but they are detected only when the symptoms worsen. And during that period of time, they happen to infect a lot of other people. So the infection spreads, right? Even before it is detected, unlike COVID, in which you showed symptoms very quickly, you can isolate the patient and maybe stop the transmission. The diagnostic access is uneven. Sometimes it has been observed that in rural settings, in order to get your sputum tested, you have to travel many kilometers. So diagnostic access is limited. Screening to confirmation pathways are fragmented. You often go to a pulmonologist, get your sputum tested. The pulmonologist then directly has to refer the patient to NTEP. So the patient now has to go to another area for getting an X-ray done, then another area for starting the treatment. So this often fragmentation breaks the treatment cycle. So also there are gaps in the data and adherence monitoring system which needs further strengthening. So the care pathway primarily in TB starts from screening of normal people for symptoms, testing them, testing the symptomatics, confirmation, initiating the treatment, monitoring treatment adherence. As you all must be knowing that treatment completion is the most important factor for TB elimination, and the tracking of the outcomes. So India's TB response is strong, but elimination still requires faster, smarter, and more connected systems at every step of this pathway. TB, a lot of innovations are happening in TB. So this is more in terms of digital technologies, right? So innovations happen in diagnostics, molecular tests, digital radiology, point of care screening tools. Innovations happen in treatment support. A lot of digital adherence monitoring tools, applications have been developed, remote follow-up systems have been developed, applications have been developed where patients are sent notifications and alerts. The real-time dashboards are there for surveillance. Risk stratification models are there. Using GIS, hotspot mapping, predictive analysis has been done. AI-enabled decision support has been made for X-rays, for in areas where expertise is not there to read the X-ray, handled X-ray machines with built-in AI algorithms where you take the X-ray image and the algorithm itself identifies or triages the patient, whether the patient needs to be referred to a higher center, and population level alert system. So these innovations are happening in the every stream. But the key takeaway from this slide, what I want to say is that advancement is not only a new test, it also should involve, and this is thing which is lacking. It should involve better integration. It should have that scalability component imbibed into it right at the point of conception of the proof of concept, not after that. What is mostly happening that innovations come, but when they are made, after that it is thought about whether it is scalable, integratable, and all, right? So what is the role of AI? AI can at the community level help in symptom screening. We can design digital questionnaires, risk scoring tools. At primary care level, we can do chest X-ray interpretation, triage, flagging of cases, For diagnosis, we can identify patterns, we can prioritize workflow, which patients need to be followed up first. For treatment phase, we can design mobile applications for adherence, alert systems, follow-up tracking. And for public health, where all the management or deciding allocation of the resources for TB happen, there we can use GIS, which is another component of a digital health, for mapping the hotspot using pin code, and identify areas which are far away from a TB center, and maybe the government needs to, uh, uh, set up more diagnostic centers near that village, or maybe identify areas where there is a lot of cases, so the government can set up mass screening camps and identify patients from that area. So AI should be positioned as an assistive and augmentation tool. It can never be a replacement for clinicians or public health systems. Human in the loop is the key component for any digital intervention to succeed in the healthcare. And a TB care continuum ribbon with AI interventions should be mapped under each step. Digital health is very critical for India's TB roadmap because it can reach high burden settings such as underserved, rural, hard to reach communities where physical infrastructure is limited. It will reduce the delay for diagnosis, as screening and triage can happen at the point of care itself. It will also help standardization across sites, and it will provide end-to-end linkage where contacts can be screened, diagnosed, referred, and monitored at the point of care contact itself, reducing the patient drop-off at each transition, which is a major problem for RNTP, sorry. Whenever you introduce any digital intervention, it gives us the benefit of providing high quality data sets. So these data sets can be analyzed by experts. It can point out where the problem is, where we can improve, and it will also provide policy feedback. So the key enabling technologies right now, since this is a short time, I have not covered these technologies in detail because that is a separate 1 or 2 hour list, that what technologies are present, which have been incorporated, which are under various stages of TRL. So the first is AI-enabled diagnostic imaging and CAT tools. These are very common, being built up. Few of them are being clinically validated at ICMR. Many of them, one of them has been, incorporated into NTP program at various state TB centers as a part of ICMR project. Then digital pathology and laboratory informatics, AI-built solutions where AFB can be automatically identified on the microscopy slide have been built up. There are portable battery-operated point-of-care devices, as I was telling about, handheld devices with inbuilt AI algorithm. The connected telemedicine platforms, mobile-based adherence tools, 99 dots has been developed by NTP. It's a wonderful tool, and it has actually helped in compliance, increased compliance and treatment adherence. The NICSHARE, the National Case Management System, is another example of a digital health intervention in the program, in TB program. And we all know that how wonderful this platform is and how it has actually improved the overall way the program or the TB patient is approached. There are real-time dashboards for program monitoring. Then there are interoperable health data platforms like ABDM. These systems are actually systems which can support scalable screening ecosystems in public health. So what is needed? I've covered many of these points before also. So clinical validation in Indian populations is a must. So most of the solutions that come to us at ICMR for evaluation, we observe that they have been built on foreign data sets. So because Indian data sets, public source, are not easily available. So the technical people have their own limitations, which is very valid. But so it is very important that these solutions should be validated prospectively on diverse Indian data sets across geographies, demographics, and settings. And performance alone in controlled trials may not replicate in field settings. Am I over my time? Sorry. Do I have time to complete?
Ma'am, just 1 minute.
Okay. Second is integration with existing health systems is important. Human in the loop design should be there in every digital health intervention. ICMR ethical guidelines provide a framework for data quality, interoperability, and governance. That is important. And tools must be operable on low cost hardware. So these are the other opportunities to accelerate TB elimination, AI-assisted screening workflows, portable diagnostic support, unified platforms, frontline decision support, multi-sectoral partnerships. So the key takeaway is that early detection, as we know, is central to TB elimination. AI and digital health can strengthen the speed, reach, and continuity of TB care. However, the impact will depend on rigorous validation, system integration, and equitable deployment, especially at the last mile. So to move from awareness to action, we need innovations that are not only advanced, but accessible, scalable, and embedded within the public health systems. That is the most important takeaway. Thank you.
Thank you, Dr. Jain. Streamlining TB elimination through use of technology will actually be a game changer. And AI as an assistance tool is what is going to make a lot of difference, I'm sure. We will cover this more in one of our panels, which is the second panel. And I would now like to, invite Dr. Soumya Swaminathan for a keynote address. We are extremely it's honored to actually welcome Dr. Soumya. Dr. Soumya Swaminathan is India's leading authority on tuberculosis. She currently serves as chair, MS Swaminathan Research Foundation, is also a principal advisor to the National Tuberculosis Elimination Program. Formerly ICMR Director General and WHO's first chief scientist, she has played a huge part in shaping India's TB research and policy landscape. Over to you, Dr. Soumya. Thank you for joining us.
Thank you, Urvashi, and good afternoon, greetings to everyone, and thank you, Garima, for that nice overview. So I wanted to give only a very brief and a high-level talk from the perspective of India's elimination goals and program and what I think we need to be focusing on. Certainly in the last 10 to 15 years, India has made progress in TB control. If you look at the baseline of 2015, which is what the WHO uses as a baseline to measure progress against the 2030 targets, our incidence is down from about, I think we were at something like 220 per lakh, and we're down to about 190 per lakh now. So there's been a decline, which is a little bit faster than the decline in other countries, but yet it is a slow decline in incidence. So obviously, we still have the world's largest burden of TB, around 25% of cases every year. We also have about 27 or 28% of the deaths, which to me is a much more worrying thing because a lot of the deaths are preventable. So from a death rate of about 35 per 100,000 in 2015, we are now down to 22 or 21 per 100,000. So from 35 to 21. So again, progress. But our goal was to get to around 3 per 100,000, because if you look at the WHO NTB goals, 90% reduction in mortality and an 80% reduction in TB incidence and zero out-of-pocket expenditure or catastrophic health expenditure due to TB. These are the three goals. On the incidence, we're coming down, but slowly, and it's going to take time. Incidence will not go down that fast because we don't have a new tool. And if we had a new TB vaccine that was highly effective, one could have said, okay, we vaccinate everybody now, then in the next X number of years, we can eliminate TB, but we don't have that. In terms of mortality, however, I feel that we can do much more. TB deaths, the majority occur in the first 2 months, and in fact, the vast majority occur in the first month. And TB deaths occur amongst those with other comorbidities. So people who are severely malnourished or who have a comorbidity like HIV or diabetes in some cases, or they have a very poor social setup and they don't have good care at home. And this usually goes with poverty, malnutrition, etc. And of course, delayed diagnosis. So if you delay diagnosis, the disease is going to spread and the patient is much more sick when they come in. Now, there was a nice experiment that was done in Tamil Nadu called the TN-KET program. This was done by the National Institute of Epidemiology, Dr. Hemant Sherwade and his team. And what they showed is that by having a very simple screening, clinical screening questions, 5 questions, you can actually find out those who are at highest risk of early mortality. So is the patient, mobile? Is he ambulant? Is a patient able to eat and drink? What is the respiratory rate? Is it, very, very rapid? What is the saturation? And is there pedal edema? So just these 5 things, no lab investigations. If the answer to any one of these, one or more, is yes, then you have a high risk of early mortality. Such patients should be immediately hospitalized, because then you can look after them, give them intensive rehabilitation care, clinical care, oxygen, IV fluids, nutrition, whatever that person needs. Or, it could be insulin for diabetes or antiretroviral treatment, depending on what the person needs. And you look after for the first few weeks, and then you can discharge. Currently, what happens is that admissions in TB have gone down, because in many places they say, we don't have an isolation ward, and there could be other practical challenges. And also the screening algorithm has not become used everywhere. So one of the first things we need to do is to train every PHC medical officer, nurse, and of course the TB staff themselves, any of these 5 risk factors, whether that person is in the clinic or at home. Sometimes it's Asha who goes home. But if she also knows that this person is very sick and should be hospitalized, you can always do that, provided, of course, that the district administration makes beds available for infectious patients. So I think I would say that our top priority should be to reduce TB mortality to as low as possible. We're still at 22 per 100,000. China is at 3 per 100,000, and that's where we need to get. So we have a ways to go, but it's doable. And I think everything that Garima said in the earlier talk about making earlier diagnosis certainly helps. Doing the drug resistance testing as well, so that the patient gets the right treatment. But in addition to TB treatment, they need these other, the support system. And sometimes patients just don't get that at home. So that's why they need to be hospitalized. So that's number one. Secondly, I would say that in India, things are very diverse. Problem in an urban area is very different from a rural area, and similarly, our tribal areas are very different. They're very spread out, small hamlets. Generally, these are all aspirational districts. People are poorer. The distance and bus connectivity is worse. So tribal and urban, I would say, requires special focus. Urban, why? Because you have overcrowding, you have a lot of chances of spreading, and that's why you see MDR TB hotspots in Mumbai and so on. You also have a lot of private sector. So a lot of people taking care first in the private sector. So it's complex. So the private sector has to work with the public sector, and Mumbai has shown very well over many years how very nicely to bring the two together. So an urban TB strategy and a tribal TB strategy. Tribal, you may require things like mobile vans that are equipped now today with X-ray, AI, and also with sputum collection, if possible, with a NAT. If not, at least take the sputum, bring it to the molecular testing lab, and give the patient results, the same day, if possible. If not, at least by the next day, and then make sure that person goes for treatment. One other point here with all of this AI and technology is that you will also start finding other lesions, other things. Everything that we find on AI finds is not going to be TB. So you've got to be prepared to have a referral pathway for all those other pulmonary lesions, which turn out not to be TB, could be early lung cancer, nodules, COPD, various other things. So our health system has to be prepared to deal with those. Next, of course, is the diagnostics, where there's amazing innovations going on. And most recently, about 2 weeks ago, the WHO actually approved near point of care testing for TB. So our dream is ultimately to have a COVID-like test, where you just do a nasal swab or a tongue swab, and within a couple of minutes, you know whether you have TB or not. You can self-test, or your ASHA worker can test you. But next to that is near point of care testing, where again, Indian companies have been at the forefront. We have startups who have developed, like UL, who have developed tongue swab. They've also developed PCR, which can be done in all the PCR machines we have across the country, which were actually scaled up during COVID. So we have a lot of extra capacity now. And what we needed was kits which could be used across different type of machines, so that you're not limiting a particular kit to a particular machine. So in high volume centers, in medical colleges, for example, you could use the PCR kit. In remote settings, you could use the tongue swab. Though the sensitivity may not be as good as a proper CB-NAT, it could be a screening along with the X-ray. And X-rays need to be much more widely used. So the NTEP is purchasing many more X-rays machines, handheld X-ray machines, which can be taken to the field, hopefully bundled with a good AI algorithm that can then do the job of the radiologist, or at least the initial job, before it has to be seen by a radiologist. And all of this, of course, is going to require good coordination between all the people involved. And ultimately, I believe that TB will have to be one of the diseases that's looked at after as part of comprehensive primary health care. So we may no longer be able to continue forever with our vertical programs. TB is a disease which coexists with many other diseases. And if you have strong comprehensive primary health care, then I think gradually it can be brought into that, so that the person also gets a more holistic care. Because what happens is sometimes you have diabetes, TB, one or the other could be missed, though now there's bidirectional screening, or you could have high blood pressure, which could be missed, or any other issue that can happen. And finally, I think research is extremely important. And I'm very happy that the ICMR is planning to launch a TB accelerator. There's still a lot of things we don't know about TB. So basic science on biomarkers, on pathogenesis, on transmission, on epidemiology. We need to keep studying those. And we also need, of course, we've done a lot on new diagnostics. Like I mentioned, there's a lot of innovation happening on diagnostics, but not so much in treatment or in prevention. So in treatment, there are some new molecules, different companies, agencies around the world. I think as part of the TB accelerator, we could also enhance the number of clinical trials that are happening in our country for treatment of drug resistant, especially, but also for treatment of drug sensitive and extrapulmonary. So again, a big gap is extrapulmonary and pediatric TB, where diagnosis is more challenging. We don't have a good biomarker as yet. Patients have to travel long distances to get specialized investigations done. And we're still missing or delaying the diagnosis of a lot of extrapulmonary TB, and in some cases, over-diagnosing and over-treating. So that, again, is an area for research. And then the final holy grail, of course, is a vaccine. And there are a few vaccine candidates now which are going into trials. But we do need still more investments. It's a challenging one to develop a good TB vaccine because, as you know, it's an intracellular organism. And the most challenging thing about it is we don't yet have a surrogate marker of protection. So it becomes very difficult to do studies. Every time you have a candidate, you have to actually go through a full phase 3 trial to look at efficacy because there is no shortcut. So finding a surrogate marker of protection would be part of the problem to be solved on our way to discover a new TB vaccine. But we need to support DBT, ICMR, and other agencies definitely need to support work, because I think in India is the place where we can actually do a lot of the research and make a lot of discoveries. And then I would end by saying that the gender elements should never be forgotten in any disease. Women always have not only unique, sensed. In this case, of course, TB is more common in men than in women, except for the younger age group where extrapulmonary TB is equally common, and lymph node TB may be more common in women. But postmenopausally, the risk of women also developing TB goes up. Plus, there are social taboos and stigma and so on still in our society, which prevent women from accessing care. It becomes a big social stigma if a family has a a young woman with TB. So those are still things that we need to break. Those the stigma. We need to talk more openly, and the fact that it's a infectious disease which is curable, it's airborne, and it's not anyone's fault for having got it, and that early detection and treatment will protect not only the person but also all those around them. So thank you very much, Urvashi, and yeah, I hope you have a good rest of the afternoon.
Thank you so much, Dr. Soumya Swaminathan, for joining us. In fact, India's diverse landscape demands a tailored TB response system, prioritizing the disease adherence with ASHA workers, as you said, district administrations, and more of collaborations that require public and private companies to come forward at the core to support bridging of urban and rural divides. Thank you so much for those powerful words, ma'am, and specifically focusing on the gender element, which also needs to be taken care of, and the stigma attached to TB, ma'am. I would just request, we have two questions for Dr. Garima. I would also request the audience, if they have any questions specifically for you, please write it in the chat. I will just take up the question for Dr. Garima. One second. What is it? One second, ma'am. Sorry. Dr. Garima, there's a question for you. How is the availability of X-ray diagnostic infrastructure in the remote areas, and how do we digitize those X-rays for AI-based analysis? Dr. Garima, are you there? Okay, so I don't think we have Dr. Garima. Maybe she's left. We will move on, ma'am. And right now we don't have any chat questions for you. If there are specific questions, we will, send it across to you. Thank you so much for joining us, ma'am. With that, I move on. Ma'am, 1 second. Sorry, we have a question. For Dr. Swaminathan, can you please shed light on dermatological aspects of TB, atypical TB? People are not aware on diseases like hydradenitis suppurativa. Sorry, I'm not get suppurativa. I hope I've got it right. Could you understand? Dr. Soumya, are you there? Oh, I think she left. Okay, I think moving on, I would now like to request the panelists for the next session, which focuses on TB elimination gaps, challenges, opportunities, and need for collaborating efforts. I would welcome Dr. Priyanka Bindru, consultant pulmonologist at Manipal Hospital, Dr. Aishwarya Rajkumar, Senior Consultant Pulmonology, Rela Hospital, Dr. Paban Nath, Deputy State TB Officer under National Tuberculosis Elimination Program, Delhi, and Dr. Medha Gandhi, Founder, Counterpart Impact Advisory. I request Dr. Ravindra Kumar Diwan, former Director, National Institute of Tuberculosis and Respiratory Diseases and Principal Consultant, Thoracic Surgery, to please initiate the discussion as moderator, sir. So over to you, Dr. Diwan.
Thank you so much, Urvashi, Sabha, and Sakshi, all of you, for organizing it. I think the tone has been already set by as senior a person as Dr. Soumya, and she has highlighted very important points as to how we stand today. Just to reiterate, I think once the National Strategic Plan we started in 2017 with the ambitious aim of eliminating TB, by 2025, we have reached certain goals. For instance, our rate of decline is double the incidence worldwide. So that is something to cheer about. And as she rightly pointed out, the mortality has shown a decline, 21% decline over the last 10 years. But
that we are not going to have or contract this disease. Then, though government has really worked good for upcoming NATs, which helps in diagnosis firsthand about the disease as well as the resistance pattern, but still it is being underutilized by the medical practitioners also. And so there are lots of things for that matter I would like.
And a follow-up question, Priyanka, because as a surgeon, I have seen cases which are clearly tuberculosis and were not diagnosed as TB. I get cases with destroyed lungs who have never received a ATT treatment, and I straight away referred for surgery. And I had received cases of lung cancer which were which were wrongly treated as TB for a long time, by the time it became cancer. So how can we stop that gap itself? And how can we bridge that gap? Because both of them are very tragic sequences.
So for that, I would say there is a lot of communication gap that is occurring amongst the fraternity also, right? We should not hesitate, like even if we are having a little skeptical in contacting our, fellow colleagues, and make sure that the patient compliance is there. Once the diagnosis is made, we should make available bronchoscopy, percutaneous needle aspirations, and any kind of surgical intervention, invasive modality, also if needed by the patient, which is not easily available to most of the people in the country still. Though even we are trying to bridge this gap through private sector and government, like you yourself, sir, hats off to you. You've been doing so much of thoracic interventions and help so many people, but still there are, and through the course which you've been trying to, tell the people about thoracic surgeries and tuberculosis, but still that facility needs to be made available to most of our population. And secondly, we should communicate. Under treatment is one of the biggest factors, sir. We should at least, make sure that compliance is better. Once we start the patient on treatment, we should take him to the end. Better counseling, better, there should be no loss of wages for that person, and so forth and so forth.
See, Dr. Soumya highlighted the continuing high mortality in TB. You worked in RBTB hospital and our own NITRD. We see that most of the patients who come to emergency and who die have been receiving ATT for less than a month almost. And that is because they are not properly, we are not able to screen people who require early hospitalization, especially severely malnourished people, diabetics or HIV people who need a hospitalization. So very aggressive strategy. I think you will be also an advocate for an aggressive strategy of highlighting those cases which require hospitalization.
Correct, sir. We should.
See, the program emphasizes domiciliary treatment, but some patients do require hospitalization and support to save the mortality, to decrease the mortality.
Yes, sir. We should not wait for that moment, to continue with the home treatment. If needed, we should make sure that they are coming to hospice as soon as possible.
And do you think we are still detecting drug resistance TB early enough to do the intervention to switch over to the second line drugs? Do we have functional or challenges to that or something like the systemic failures related to that?
No, sir. The only thing is like the patients are coming in late to us, but otherwise the government has made sure that the facilities are in place and working properly. Even though there are certain technical glitches we do face at times about the availability of the cartridges and sometimes, but per se we are able to detect it very soon.
Okay. Thank you, Priyanka. I will move on to Dr. Pavan, because Dr. Pavan is, and but stay with us. We'll have more follow-up questions later on. Dr. Pavan, because you are directly dealing with the program. So what do you think, what are the strengths of the program? We have achieved much by 2025, but all of us knew earlier also that we will not be reaching the goals as initiated in the TB elimination program by 2025. But we have reached some aspects of the goal. The government was very proactive in supporting the program. So what do you think are the strengths of our program? And do you think there are some weaknesses on which we can work upon?
Yes, sir. Thank you, sir. Sir, our program, the TB elimination program in India, it is aligned with global standards. We definitely have strengths here. Firstly, we have a proper mapping of the vulnerable populations. We have recently also received AI notified high-risk areas throughout the country, which needs more focused, more intensive approach. So, with those, what we are doing is that we are getting the handheld X-ray machines so that the field X-ray can be done and the action can be taken at the field. And we have the NAT machines, the CB-NAT, the TrueNAT, the PathoDetect machines. We are utilizing them. So these are the system strengths. It lies in the infrastructure. That infrastructure-wise, we are becoming better. And other strengths are, of course, the human resources. The human resources also, a lot of human resources have been recruited. In our Delhi state also, I can speak about Delhi state. In our Delhi state also, a lot of human resources have been provided. And we are also receiving help from the NGOs and the PPSAs, which are helping us in achieving our goal. And further, sir, we have a very nice tool, sir. It is the Nikshay app, the Nikshay portal, which is giving us the data regarding which patients are getting notified, what patients are in which groups, as if like Sarabhi ma'am has also, you had also mentioned regarding the requirement of admission in certain patients, like people with diabetes and those groups. We have it in the portal. We have the differentiated TB care approach, where we differentiate patients according to their clinical conditions, their vulnerability, and then we decided that whether this patient needs admission. So structurally, sir, there are lots of strengths in the program. We also have for prevention, we have TPT. Vaccine is, of course, we do not have it right now, but we have two useful tools for prevention of the disease. One is the TPT and the other is the airborne infection control measures. So if we stress upon those, we can also prevent the TB to a large scale. So, sir, with these, then further regarding the, I think you asked about the gaps. So the gaps, I would like to say that we have a few, but of course they are interfering. So firstly, I'd like to mention the private sector integration. So in Delhi, we have a lot of different patients in urban slums among the middle classes also. They all go to the informal sector, like ma'am had also said, that they go to the informal sector, they seek care in the private sector first. And while notification has improved, but true integration of the care pathways, which lies in the outcome tracking, the adherence monitoring, and the treatment, and the following the program defined treatment regimens. So we are lagging behind in those things, and as a result, we lose some critical time before the patient enters the standardized care pathway. And so then, secondly, sir, I'd like to say that it is regarding the TPT. We have the tool, but the implementation remains limited. In the private sector, so especially the uptake of TPT, particularly for the household context, needs a significant strengthening. And so thirdly, the community engagement and the stigmas. So Delhi has a highly diverse population, urban slums, resettlement colonies, and gated communities. So community mobilization is heavily dependent upon the ASHAs, who are already overburdened at present with other programs also. So we need more context-specific engagement strategies for different population groups, for all these, the urban slums and the gated colonies. In addition, such stigma continues to influence care-seeking behavior, especially in dense urban settings and among certain population groups, leading to delays in diagnosis and poor adherence. So addressing this requires targeted community-specific communication strategies, not just a general awareness messaging. Then, so fourthly, we have a data to action gap. So the niche, like I said, it provides a strong visibility, but the system does not consistently ensure time-bound action for high-risk patients. Like you said, sir, we mark the patients as it is falling in certain vulnerable groups of certain high-risk groups, but we are not encouraging the field staff to follow up on those patients with vigor. Because they need I think intensive monitoring, that whether what steps have you taken to get the patient properly assessed, or even to get him admitted. And so I think the Nikshay portal, because AI is also being discussed here, the dual addresses should be enabled in the Nikshay, so that the migrant population, especially regarding the migrant population, two addresses can be given. And the two addresses, what we can do is, if the patient becomes untraceable, is lost to follow up, then at the same time, two different details will get triggered, and they can follow up with the patient. They can, I think, coordinate and at least give us some better outcomes. And so additionally, there is need for a more simplified and actionable dashboard in the Nikshay portal, which the STOs and the DTOs, they can monitor at all times so that whenever the key performance parameters, the indicators, those are visible in a weekly or a monthly basis, which get updated automatically and do not need effort from the DTOs or the STOs because they are not technically that capable. So it should be visible very prominently in the dashboard. So that is also, I think these are a few of the gaps. So my view, so this is my view, sir.
Thank you, Dr. Pawan. You have actually very extensively treated. But regarding the admission, for instance, ITRD and RBTV, the two hospitals will be admitting a serious cases which require admission. But why not Deen Dayal Upadhyay Hospital, Ram Manohar Lohia Hospital, GTB Hospital, some of the government facilities which are existing? How can we fill that gap that they also admit these serious cases? So there is no problem in getting the care that they deserve.
Definitely, sir. I agree with you, sir. Sir, because I've recently learned of a DO letter which was circulated in July 2024. It was regarding setting up of reserving at least 5 district hospital, at least 5 beds in district hospital and at least 1 ICU bed in each district hospital for the TB patients. So it was stressed upon by the Secretary of Government of India, and it was circulated to all the chief secretaries. So that is one of our, I think I'll say tools so that we can stress upon this thing. So, and because we have our latest AIC guidelines also, which give very clear guidelines on how to set up the DRTB wards or how to set up TB patient wards, and even the ICU. For the ICU also, they have given us a very proper guidelines. So we can use them, and we are actually working on it. We are actually trying to involve our secretary so that we can stress upon the MDMSs of these hospitals, district hospitals, so that they can also start, they can reserve, they can either make an isolation ward or they can reserve in certain corner 5 or 6 beds for TB patient in each hospital.
Thank you, Dr. Pawan. Now we move on to Dr. Aishwarya, because we have been talking that so much of patients go to the private sector, and you have been working in the private sector. Your inputs will be very valuable. Number one, what are the challenges that we are facing as a private practitioner while treating TB? And while understanding that most of the patients do go to the private sector, most of the program is centered around some
Sir, am I audible? I mean, there was a glitch in between.
Yes, you are audible.
Thank you, sir. So, completely agree, because though our National Tuberculosis Elimination Program has been very strong lately, that fragmentation between the public and private sector has become a huge barrier for us right now for TB elimination. And being in private sector, I can give out a few reasons why I feel that patients is still preferring on private sectors for TB treatment. One is even if I get a patient, so for example, I am in a high volume transplant program, and we're also seeing a lot of cancer patients in our setup. And these patients are patients who are with us for a very long time. Like, say, if a patient is into a transplant program, they are with us in this journey from the pre to post transplant for almost 3-4 years. And during this process, say if this patient is going to get diagnosed with tuberculosis, and most of them are like post-transplant, we see at least 30-40 patients getting tuberculosis in about 6 months to almost 2 years. So such patients, if I just notify them to say a public sector saying henceforth you will have to be on treatment with the set program, that either my patient is also not comfortable, and to be very honest, sir, even as a referring physician, I would just don't want to be like a doctor who's just notified. This is my transplant patient, and certain expertise will have to be going in hand in hand to each other. So say if my transplant patient is going to be put on medications like rifampicin, these are medications, pyrazinamide, these are medications that can interact with the transplant medication as well, but they can extremely interact with tacrolimus. So I do not want to be just a notifying doctor. So that was a point that even I would, as a physician, I would say, I just not even get into the patient point of view. From the physician point of view, most of the time, I just feel like this should be a hybrid treatment. especially when it is coming from a private sector referral. I would like to be notified about my patient. I would like to be, I would at least like to know the feedback from my patient as to how my patient is. And it is not just to like, I have reported that there is a TB patient here. So if it's a straight cut case, understood. So many times, like we deal with a lot of HCC patients, and a lot of HCC patients here, we think that even we from our side have treated them, liver transplant would be done, or a hepatectomy would have been done on this patient. And a couple of months later, these patients come with a mediastinal lymph nodes, and we being a high volume EBUS program as well. Then with EBUS, we find out that this is an extrapulmonary tuberculosis sitting in there. And such patients, I would, even if I refer the patient to a public sector, the patient still wants to be associated with us. So I feel if we're working on complete elimination of tuberculosis in our country, I think the private public sector working hand in hand should be even established in terms of physicians per se, beyond the patient itself. So we should establish, Nikshay has made it a little more comfortable these days, but I find even that is, the notification could be a little more less intrinsic. There could be some interfaces that could be, that could make it easier for us, or if there is a real-time notification of someone visiting us frequently, wherein we get inputs on our patients, all that would make it easier. And public sector, one is patients who are there with us long term, and two, near the patient feeling, they don't want to be, many patients are, from VVIP patients, or they just don't want their history to be known, the confidentiality, and the patients does not really want to, when we say public sector, they just go off after that. Like they either go to another private sector doctor. I don't think they end up in a public sector program. So these are things that I've faced in my practice.
Dr. Ashwin, thank you. Actually, you have brought out but what you basically meant was probably private sector needs to be given greater freedom. But I think there already exists a program in which a corporate hospital also decides to treat the program as per the national TB guidelines. They're welcome to be a part of the program. They only have to notify and do that. That is there. Of course, there was some drug the second line drugs for which there was something that we should not liberally release them into the private sector. Otherwise, they will also develop resistance very fast. But I think their guidelines are being changed accordingly there also. And private sector participation over the last decade has increased in the treatment of tuberculosis. So post-transplant, which are definitely a very special group, I understand. But there must be other cases like simple tuberculosis coming to you for the first time, extrapulmonary tuberculosis, or sometimes in a patient whom you are treating and resistance is being suspected. Then just highlight those challenges too.
Sir, agreed. There are even simple case referrals. I'm just saying that if my private sector patient has a stigma to go and see doctors in the public sectors, if this patient feels that for confidentiality issues, if there is much more communication with me and the public sector, I am referring all my patients. So we are notified. Our Nikshay program here is pretty strong. But I just feel like if I'm notified about my patient, like I get a feedback too from the public sector, as in how my patient is, and so that I can also be in touch with my patient frequently. So that way there is a bridge that's developed. And here the patient, the treating physician, as well as the referral physician are all on the same page. I think that is definitely lacking in our country.
Dr. Pavan, can you make a point on this? Because this has been very specifically highlighted by Dr. Aishwarya. Before I move on to Dr. Medha. Yeah.
Yes, sir. I agree, sir. I think autonomy should be given to the private sector also. And like sir, you have said, the drug-resistant medications, I think, sir, DRTB committees, they can be formed at the private sectors, and we can distribute we can give them the medicines as per the DRTB committee recommends, and we can distribute it to the patients. And regarding the further collaboration that ma'am is speaking about, I totally agree with her. So,
okay, we'll take it up further. First, I talked to Dr. Medha also because she has been waiting. Dr. Medha, welcome. What are your thoughts on the program so far, the success we have achieved so far? It's whatever our setbacks, whatever we have failed to achieve, because you are working from a setting which is neither government nor private, and you can speak from that side. Dr. Medha, please.
Thank you so much. I hope I'm audible.
Yes, you are very much.
There was some tech issue before. I think a lot of points, Dr. Vandan, have already been raised, and there isn't, we're already talking about the challenges that we're facing. I mean, if we look at the policy framework, there is a lot that is very positive in our policy framework, right? A lot of it has already been said in terms of directionality. I look at it as a sort of as a D model, right? That there is a direction, there is a political commitment that exists that talks about elimination before the SDG goal. Now, the guidelines and all exist. The question is, how are they interpreted and implemented in spirit at the national, state, and sub-state level? And we've already heard of the issues that are being faced by, especially the private sector providers. And while there is a very positive intent, as we heard from Dr. Pawan, in the government to build those bridges, but there are challenges that exist. But having said that, the fact that there is political commitment behind it is something that cannot be denied. And I think we need to capitalize on that momentum to move things forward. There is also a very intent, there's a very positive intent in the design, right? When we look at the whole protocol around the design, treat, prevent, and build mechanism and model, which is an integrative model that offers an opportunity. Now, the question is, how are we going to create opportunities for sharing the kind of issues that have been raised today? Dr. Garima talked about innovation that is happening, right? And Dr. Soumya called out for more innovation in the treatment space. But how do we bridge that gap, and how do we make sure that we have a more intentional partnership model to be able to take that forward? We have a great infrastructure for the diagnostic space with molecular labs, over 6,000 plus molecular labs, and close to 25,000 microscopy centers. And that is purely in the public sector. And I think in terms of numbers, that is very huge. What I think is really required now is to map it as per the caseload, and you will be better placed than I am in talking about this in terms of how these map to where the need is and how we need to ensure that people are able to access it without having to face stigma and delays. And also being mindful of the fact that there is the whole point around wage loss when people are coming in for their services. In addition, I think from a policy landscape, the fact I think that all of the speakers before me have highlighted, which is the digitization aspect. And I think the opportunity here is for us to share with the world how we've been able to build that model and to create that seamless pathway between, technically, theoretical pathway between the public and private space, but of course, looking at what the challenges are. If you'll allow me 2 more minutes, there are just a few more points that I wanted to talk about. One point that I do really want to highlight is the issue around the diet, nutrition, and social protection. Right? We do have the Nikshay Poshan Yojana that is available. And I think that is a very important policy initiative. We forget very often how important something as critical as diet is in terms of treatment. And we get so driven and motivated by technology, diagnostics, service delivery, treatment protocols, that the basics sometimes get missed. And for TB protocol, there's enough evidence to show how important that is. And I think that is an area that we as a group need to amplify, that diet is so very critical, and the whole issues around social protection, managing the social dimensions of the disease. Stigma, as Dr. Soumya Swaminathan had also highlighted, is very critical. And with that, I'm not going to talk about the public-private partnership because Dr. Aishwarya has already spoken to that. I do think that local governance has a very critical role. We have the framework in place. And I think that is where we have to move beyond a public-private to a public-private civil society partnership and leverage that with a trust-based ecosystem so that we're able to leverage the TB Mukt Panchayat model effectively and bring about those changes, and not just in the rural areas, but also in the urban areas where the urban poor are able to leverage that. So expanding this beyond. And 2 areas that I think need to be further strengthened in our policy framework. One is disinformation. There is a huge challenge around that. So how do we have a better social listening mechanism? How are we informed by repeated behavioral insights? As much as we are investing in technology, we also need to understand how people are making those decisions. And we give that very low priority when it comes to any disease, with TB especially important, and community-based trust. And my last point here is around the gender dimension of TB. In terms of reported data, we know that men are, there's a higher caseload in men. But the question is, are women coming forward to testing? At what point are they coming forward in testing? Are they following through on the treatment? How are we going to be intentional? We heard about talking about younger women and the stigma involved. We also heard about menopausal women. But I do think that TB in pregnancy is also an important area. So looking at it as a linkage between TB and sexual and reproductive health and nutrition is an important paradigm. So there are great opportunities that we have in the policy framework, and these two areas, according to me, that need to be strengthened further. I will pause there.
Thank you. And Urvashi, do we have a time for summarizing, or are we already over the time?
So we are already up. We don't have much time. We are already running behind. So maybe one question we would take, you could just wrap up the panel, and then a few questions. If 2 questions we can take up for the panel, and then we can close the panel.
Just like to just wrap up, I think the important points which have come in is that already there is a lot of information available about tuberculosis, and there should be no misinformation. Very simple diagnosis about diagnosis, who to seek the diagnosis, where to go for treatment, and number 2, ability to give help to those who are very weak, those who are having comorbidities, etc., those who are malnourished, and admission facilities for that. Number 3, private practice and private practitioners should be made a part of the program as such. And number 4, newer innovations are of course needed, but just artificial intelligence itself will not cure anything. Its implementation at human level, in a simple level. From my large experience, patients want to know where to go, what to do. And generally, whenever we say that patients are leaving the treatment in between, I have found most of the time the doctors have not treated them correctly, advised them how long to take the treatment, how it was very important. So simple steps and simple health education in the community at large, and implementation of the robust mechanism, technology, and the program that we have is what is the need of the hour. I think, thank you so much, every participant who have contributed very well. Because of positive time, I'm not able to ask follow-up questions, and I wrap up this program. Thank you. Over to you, Urvashi and Sakshi. Thank you.
Thank you so much, Dr. Diwan and all the other speakers. There are 2 questions at the moment. For Dr. Medha, there's a question that there is a lot of diagnostic infrastructure available. This is good news. Why is this underutilized?
What I understand on this, and I would request for the clinicians and Dr. Pawan also to come in on this, is that the 2 issues that I talked about, which are not being addressed as much as one would like for them to be. One is around disinformation, right? So the whole fear and the stigma around accessing services, that is a huge setback. And the other being that, the challenges that people face in coming forward, the continuity of the TB program, the cycle of taking leave from work, whether it is formal or informal, coming in for services, then following through the delays within the system that you have to deal with. I think that is also an important area to look at, and how can we strengthen efficiencies in that. I'll pause there and hand it back to Dr. Ravindra to supplement that response, and maybe anybody else from the panel who wants to supplement that.
I think, you have summed up so well. You have discussed so well. And I think I still feel that TB treatment, diagnosis, its dissemination is very simple. Sometimes we only make it more complicated. And nutrition is a very important aspect. All of us knew that those who are nutritionally weak suffer the tragic consequences of TB. That's very important. There are other points to be highlighted in addition to the existing knowledge, which is very much available already.
Agreed. Totally.
Okay, Vash.
There's just one more question that we would take. So there's the question is, many people in rural areas experience adverse reactions to ATT and stop treatment on their own. So what they're suggesting is, can something be done, in terms of providing proper counseling and preventing and saving these patients? More or less, you've covered. If anybody wants to answer.
One who wants to make it,
Yes.
Dr. Pawan, I will give this question to you.
Yes, sir. So adverse drug reactions, I think these are already being reported. And regarding the rural areas, in Delhi, we have the urban slum settings. The adverse drug reactions that are being reported, they are being followed up. And the counseling part, regarding the counseling part, we already have newly recruited counselors since last year only. The patients who are newly diagnosed and who are notified, they are going through the counseling process. So it is being done at present. So results, I think it will be visible after some time, because it has been started recently only.
What about the 24-hour helpline which was available for TB patients registered in the next check? Because I suppose the first point is when the patient start taking treatment, he has to be told that some side effects may take place,
Yes,
which
sir.
will go away with the period of time, and
Yes, sir.
some we may have to stop the medicines.
Yes, sir.
But the helpline which was available, is it still functional?
Yes, sir. The helpline is functional. They can call the number and they can report the adverse drug reaction, which will then get triggered to the concerned DTO, and he will guide the appropriate staff, the TBHBs, to follow up on the patient.
So I think it's very important to tell the patient that helpline number in the beginning, at the start of the treatment itself.
Yes, sir. Definitely, sir. Regarding the helpline and the 99 dots also. Yes, sir.
Okay, Urvashi, I think we have overstretched the time a little bit only. I have been well within time, and you can go ahead.
Yes, I think maybe we can take more questions. There are questions coming in, but we'll take them towards the end of the session because we're already running a little late. Thank you so much, Dr. Diwan and all the other panelists for taking out time. I would request you to please stay. And as we move on to the next session, which is, I would invite Dr. Jessie Josephs. She's a Senior Manager, Global Access Research at IAVI. She's an expert in vaccine access and public health policy, and her work focuses on optimizing immunization approaches in resource-limited settings like India. For TB vaccine program at IAVI, Dr. Joseph collaborates closely with national and global stakeholders and experts to advance equitable and timely access to TB vaccines. Over to you, Dr. Jessie.
Thank you, Urvashi, for such a kind introduction. I will start sharing my screen. Is my screen visible?
Yes.
Okay. Good afternoon, everybody. It's a pleasure to be a part of this session on World TB Day and talk about a very important topic that has been specified also by Dr. Soumya as a holy grail for TB elimination. So I'm here to talk about TB vaccines in fast-tracking TB elimination. Throughout the presentation, I would be briefly summarizing why we need TB vaccines, what does the current TB vaccine pipeline look like, what are the challenges, what are the global efforts to enable development and introduction, what is India specifically doing for enabling these issues or for addressing these issues, and for development and introduction of new TB vaccines, and what more still needs to be done at a country level. It's already been specified by all of us, and we are also aware about that. TB remains a leading infectious disease killer globally, with India bearing the highest burden of cases worldwide. Despite significant efforts and advances that are being made in disease management, we still have several million cases of TB occurring globally and in India. It is well understood that TB treatment alone cannot eliminate TB. Also, because of the long and demanding treatment with complex modalities, there are issues related to treatment adherence and also growing antibiotic resistance, which is making it even more harder. Therefore, it is well recognized that there is an urgent need for a safe, effective, and affordable vaccine to reduce both transmission and prevent TB disease. TB vaccines is recognized as an essential part of the WHO TB strategy. We currently only have the BCG vaccine, which is protecting young children from severe forms of TB, but has a variable protection against adult pulmonary TB. A new effective vaccine can have high health and economic benefits, help fight antimicrobial resistance, and also advance health equity. A recent analysis done by WHO in their full value assessment shows several million cases and deaths that could be averted with a new effective vaccine, several cumulative treatments that can be averted and thereby also contributing to decrease in antibiotic resistance by a new TB vaccine, and also estimated a decrease in TB program cost and catastrophic TB expenditure that is often seen during the long duration of TB management across the globe. However, while these advancements are being made, there are several challenges which are seen, which are key hurdles for a new TB vaccine development. Some of these include a complex mycobacterial TB biology, which Dr. Soumya also mentioned, is its intracellular pathogen, and it is complex with a significantly underfunded research. Another key component for a delay in vaccine development is a long and complex trial, which are often seen with these vaccines, which become often unsustainable. One of the key reasons for this is a scientific barrier, as has already also been mentioned, that we do not have correlates of protection which are reliable. What it means is that we are not able to we still do not fully understand immune responses, which can actually predict protection from disease, and which causes evaluation hurdles. And with no quick test, it's difficult to show if the trial is working at an early stage, which again contributes to the long and complex trial. Lastly, in the case of new TB vaccines, we are targeting adults and adolescents, which is unlike what BCG vaccines have been doing. While these hurdles exist, the global efforts are underway to drive collective responses by trying to pool strengths and resources to advance access to TB vaccines. Some of the innovations that are happening are in the areas of vaccine research, development, and also implementation, where we are trying to see how the existing pipeline can be diversified. We'll be looking at some of the most recent advances that are being made in different vaccine molecules. There are efforts to harmonize the development pathways and also accelerate timelines for approval through harmonized or accelerated regulatory pathways, something that we saw when COVID vaccines were implemented. Lastly, there are efforts to prepare for introducing these vaccines through market shaping efforts, generating country-specific evidence in terms of what could be a useful implementation strategies, and also start establishing strategic and reciprocal community participations, as we have seen that in case of TB, stigma and hesitancy can be a huge barrier even when a new vaccine is introduced. Lastly, there are significant efforts that are being made to fund commitments for funding the support for vaccine development, and innovative financing strategies are being adopted across different stages of the continuum. At this stage, the TB vaccine pipeline has never been more promising, and still there is a need to take timely action to help translate these vaccines into reality. There are currently 17 promising vaccines in different phases of clinical trial, with indications ranging from prevention of infection, prevention of disease, prevention of recurrence, and also for therapeutic use. These vaccines are targeting different target population like elderly, adults and adolescents, or in infants, along with those with previous history of TB or living with TB. Some of the vaccines, such as M72, MTB-VAC, or VPM1002, have shown promising developments, which have just completed their phase 3, which are or have completed the phase 3 trial, and have renewed the interest and global commitment towards TB vaccine development. There's several innovative platforms that are being explored, including viral vectors, protein adjuvant, or mRNA platforms, which are of particular interest. As an example of recent development, M72 showed efficacy of around 50%, which is good for a TB vaccine. So while these developments are ongoing, this provides an opportunity to focus on how these vaccines can be translated actually into implementation. Even in our country, India is actively involved in TB research and development. Serum Institute and ICMR complete phase 2 and phase 3 trials for different indications, and the potential for their use is being explored based on efficacy signals. We also have the phase 2 trial for MTB vac ongoing in India by Bharat Biotech. Apart from that, the Government of India, the Central TB Division, rolled out the adult TB vaccination, which is one of the first adult BCG vaccination to happen across in the world. The program was rolled out is currently being rolled out in across 24 states and 6 prioritized high-risk populations, with additional plans to be explored based on the outcomes. The adult BCG vaccination is a good example where we saw the intersection on integration of the digital health, as mentioned by Dr. Garima. It explored and implemented the TB-Win platform along with the Nickshare platform to ensure that there is a timely access of vaccination to the entire population. In addition, there are efforts led by ICMR and Department of Biotechnology to support research and development in terms of in terms of enabling TB vaccine evaluation, and also ensuring that there are consortiums and mechanisms to have genomic surveillance for TB pathogens. While there are continued efforts happening in TB vaccine R&D, these efforts have to be supplemented by efforts towards access and policy preparedness to prevent the delays which are usually seen in low-middle income countries like India for other vaccines, even after the vaccine is available. This requires that country readiness to ensure timely implementation and access and uptake is critical. With this regard, India has also started making efforts to enable timely vaccine introduction, evidence generation, which is one of the key elements for ensuring timely policy translation has been ongoing in the country. We have a TB vaccine modeling study that is ongoing through ICMR, NIRT, National Institute of Research in Tuberculosis, in collaboration with National Disease Modeling Consortium, THSTI, and the Central TB Divisions, which is exploring different vaccination strategies which would cause maximal impact in TB reduction once a new vaccine is introduced. We're also exploring, the Government of India is also trying to generate lessons from one of its kind BCG revaccination in adults, along with other adolescents and adult vaccination, which can inform future TB vaccines, especially because this is going to be given in a population that is not usually addressed through the universal immunization program. Along with that, a timely demand forecast and costing can help establish collaborations with the industry and prepare for supply planning. Likewise, there has been regional dialogues that have been happening. ICMR-led collaborative efforts with other development partners initiated a Southeast Asia roundtable at the Regional World Health Summit earlier last year to talk about challenges and solutions for promoting vaccine R&D and financing in the region. While several efforts are ongoing, we need to recognize that there are additional enablers which, when timely adopted, can ensure that there is a fast tracking of TB vaccine uptake, development, and rollout in the country. These include continued political commitment and government stewardship for timely decision making, a scientific leadership which ensures that the decisions made across the entire continuum from development to access are robust. There are efforts required to optimize the clinical trial designs and processes, along with harmonizing the regulatory pathways to ensure that there is timely approval and there is a safety and safety established while these products are being evaluated. Once we have these vaccines, there is a requirement to scale up the manufacturing. We already, as a country, have a huge inherent manufacturing capacities, and there is a need to integrate the existing capacity to ensure that TB vaccine is also available at a larger scale. Lastly, at a system level, it's important that the vaccination strategies are evidence-based. Additional efforts can be done to support the ongoing efforts by the country and ensure that we have a health system which is well prepared to implement immunization across the life course, and have a community that is well prepared and acceptable to take a new TB vaccine. With this, I would like to summarize and end by saying that an effective TB vaccine could be a game changer for elimination and demands sustainable effort and timely timely interest for ensuring that there is a suitable access to TB vaccine at the earliest. Thank you.
Thank you, Dr. Jesse. Thank you for underscoring the need for research, which a point which Dr. Soumya also made. It is also very encouraging to hear that TB vaccine landscape has never been more promising, and the work and the policy preparedness that needs to be complemented for making advances into real world vaccines. Thank you so much, Dr. Jesse. Now we move on to the next panel, which a lot of speakers have already touched a little bit on AI-led innovations in the fight against TB. This is arguably one of the most exciting panels also, and I would now request Professor Dr. Urvashi B. Singh, former Deputy Director, National TB Elimination Program, Ministry of Health and Family Welfare, and now Professor and in charge, Tuberculosis Division, Department of Microbiology, AIMS, New Delhi. I would invite her. Dr. Srishendu Mukherjee, Managing Director, Vadwani Innovation Network. Mr. Narayan Rao Sripada, Founder and CTO, Salsit Technologies. Dr. Amit Kharat, Co-Founder and CEO, Deep Tech. Dr. Mayank Mittal, Technical Expert Lab, Hindustan Latex Family Planning Promotion Trust. And with that, I request Professor Dr. M. Puri, Consultant Chest Physician and Professor at NITRD, to please take over as the moderator for the panel. Dr. Puri? Can you hear us?
Yes, we can hear you, Urvashi.
I just talked to Dr. Puri. He said there's some connection problem with him.
Is Dr. Srishendu on the call?
Yes, I am there, Urvashi.
So, 1 second. At his end. Just please just give him a minute. We are just trying to sort it out. speakers. Uh, while Dr. M. Puri is going to join us in a few minutes, can we just go ahead with a brief introduction by all speakers, and we can start. He has already shared, you've already speaking to Dr. Puri. Can we just start the discussion? Is that okay, Dr. Shishendu?
Yes, we can start. That's not a problem. But I think he's the moderator. He has given us some thoughts on the background of the questions. I can start speaking from my end. But I think whatever you tell me, I'm ready.
Sir, initially, whatever discussions you've had with Dr. Puri, maybe you can just, I think Dr. Urvashi has already spoken to him, and you've also spoken to him. So maybe if he's taking a few minutes, we can just start the discussion.
Yeah, so Professor Urvashi can start. She's senior and she's quite into the field. I am a funder innovator. So I think Dr. Urvashi,
can you begin?
Or I can begin.
Ma'am, are you there on the call? Mute, I think she's muted. Dr. Shishendu, I think.
Okay, I'll start.
Maybe you can start while she's there.
Can you hear me?
Yes, we can hear you.
Thank you, Urvashi, and thank you.
Sorry for the disruption. I think tech issues are sometimes
No,
there.
thank you. I think Urvashi and the
No
first check team for this to speak on the World Tuberculosis Day. I think this is a problem which we have been fighting since centuries, and I have been listening to all the speakers before me. It's a big challenge to.
Sorry to interrupt. So he's there already on the call. Dr. Puri, are you there? Is he unmuted? Yes. Yes, Dr. Puri is there. Sorry. Yes. So can you unmute, please, Dr. Puri? Yes. Thank you.
Can you see me now? Yes. So good evening, everyone. Sorry for the technical disturbances. And we are here today to discuss the artificial-led intelligence-led innovation in the fight against tuberculosis. Tuberculosis is a persistent threat to the human community, and it is still affecting the India, and India bears a great significant burden of this disease. And in 2024, around 28% of the global deaths were due to tuberculosis in India, and total 25% of the global TB patients were India. And though we have significant improvement in the treatment coverage, and the incidence rates has decreased since 2015, but still a lot has to be done. And I think the artificial intelligence can help us to find out those cases which are not has been detected and which has not come up to the program. So to explore these AI-led initiative and innovative, we have this discussion. And on this our panel, we have experts from All India Institute, Professor Urvashi and Dr. Shishendu Mukherjee from the Vadhwani Innovation Network, and Mr. Narayan Rao Siripande from the CT Celestic Technology, Dr. Amit Kharate from the Deep Tech, and Dr. Mayank Mittal, who has a technical expert in the lab of the Hindustan Latex Family Planning Promotion Trust, and he has worked for more than 10 years as a microbiologist under the National TB Elimination Program in Haryana and Uttar Pradesh. So before wasting much time, let us come to the first question. I will ask the first question to the Dr. Urvashi. So Dr. Urvashi, can you tell us that with the artificial intelligence being applied across the TB care cascade from sputum analysis to chest X-ray and contact tracing, where is currently delivering tangible value and where is it still showing promise? but awaiting further validation or implementation. Dr. Urvashi.
Yeah, good afternoon to everyone. And there has been a technical glitch at my end as well. Uh, my compliments to the team organizing, and it's been a pleasure amongst so many experts to share our thoughts. So, frankly, there is a huge scope where AI could contribute, and I think we have at least 3 innovators with us who will be sharing their experiences, their challenges they faced, and how they're able to contribute to the program. So, in fact, the question that you asked, Dr. Puri, is very valid. Where all is AI able to contribute to the program today? How I would like to say is maybe today AI is, just taking over to support the program, but going forward, we believe it will be able to help us significantly more, in fact, in more areas than it is helping today. So, as you rightly suggested, if we begin with X-rays, that is the first step, I would say. You're all aware that the program expanded the screening strategy in a big way. What we did was we rolled out screening of all vulnerables using X-rays. And today that was possible with the help of AI and, in fact, tools that have been developed which are supporting us in screening these patients. We expanded to these vulnerable groups, which have been known to all of us for several years. But, this was an initiative that the program took recently because we realized the vulnerable groups are immunocompromised. They could have subclinical or asymptomatic TB, which is a well-known fact in the sense I have published myself in the year 2015-16 that diabetics may not be aware, may not be symptomatic, but they have culture-positive TB. So that same experience I brought into the program, and we expanded our screening. We started doing active case finding in these vulnerable risk groups, and that is where the WHO recommends X-rays as a screening technique, which offers 94% sensitivity. Even NAT does not offer that much. The NAT at the best offers 86% for screening. Now here we have deep tech with us today. We used the IPR tool to help us read the X-rays at the periphery, and the tool identifies normal from abnormal X-rays. So practically, we're not using X-rays for diagnosis. We're just using it for screening, followed by confirmation by NAT, and that is where the IPR enabled us to do that. That's a government-developed and validated technology by ICMR, developed by Department of Atomic Energy. And we would, in fact, there is a lot of effort being put by other companies as well. Cure AI, Deep Tech, everybody is working hard to provide provide tools rather with better sensitivity, better specificity, and every day the work keeps on improving. Because what they're using is data which is now being made available to them. What they needed was DICOM images. Moving on to the other roles that AI is helping the program with, Vadvani, Dr. Sheshendu, who is here with us today, has come up with several tools that are
Dr. Urvashi, I will come one by one. So
yeah.
my question
I was trying to address all your questions. Since you asked about sputum, I
thank you
thought I'll
for
address
addressing
them.
my point of view. That is still there is a scope to validate various AI tools for the use of the National TB program. And you have very well highlighted the need of the screening. So one thing is very clear, the screening is required, but for screening, the chest X-ray tool is the must. And it is the #1 screening tool. But the problem with the chest X-ray is that there are a lot of inter observer errors. And the timings is also consumed because in the government setup, usually the OPD is on the every third day, the patient is coming. First, he will be in the queue for a meeting the physician, then going for
Yeah.
a chest
Sir, I'd
X-ray.
like to address that.
Then
What
this,
we strengthened the program was with handheld X-rays
uh,
for several benefits that the handheld X-rays offers to the program. One, these offer less radiation. So, even as a
Dr. Urvashi, I will interrupt you. Here we are discussing how can we use the AI for these screening purposes, because we
Sir,
know
since you
that
brought up queues in the OPDs, I am telling you that the X-rays with the massive, impact that we have created under the program, several handled X-rays have been procured. They are being mounted on vans, the medical
that is
units.
I am
Let me
coming and
finish, sir. Yeah, I'll not take too long. These are being onboarded onto the MMU vehicles. These are which are being sent to different villages. In fact, as far as villages and camps are being organized in these villages. So there is no, the OPD level or hospital level screening is not what I'm referring to. I'm referring to active case finding in the field, where as of today, what the several publications recommend is screen more people. So when we know the vulnerable risk groups, the 8 risk groups that I mentioned, the geriatric, the the BMI less than 18.5, smokers, alcoholics, past TB, household contacts, all these these vulnerable risk groups, if we screen them, we'll catch the TB early. They may have asymptomatic or subclinical TB, which can be picked up using an X-ray. Handheld X-rays offer advantage of low radiation. They can be taken to the patient rather than the patient having to come to the hospital. They offer a good sensitivity of screening. Of course, confirmation is using a NAT. And this is where the program is now moving. It's moving to active case finding.
Okay,
And we are
thank you.
strengthening it. So you would be attending the Abhiyan's launch tomorrow, where 158 villages which have more TB burden. Again, thanks to the tool by AI, by Vadvani AI, they have brought us a tool which can actually differentiate low burden from high burden villages. And what the program is currently focusing is the high burden villages, because what we need to do is break the chains of transmission.
Okay.
This is another AI tool, possibly the audience today was not aware of. Thanks to Vadvani, they have brought this. And also they have given us a tool to read the line probe assay, where errors can happen by technicians. Of course, technicians are trained, very well trained, but then the AI tool enables us to read clearly and without errors. This has in fact been rolled out in the Nikshay. The results are updated on the Nikshay directly. And of course, I'll let Dr. Shirshendu add more to the other tools they have brought up. I hope I've answered your queries, Dr.
Thank you, Dr. Urvashi. So what I can conclude from your this, that only the chest X-ray has been used in the program by using the artificial intelligence. Then I will come later on with the other modality like the sputum. I will come later on.
Sir, I have added that we are
will I
using
come later
AI.
on.
We are
Now I
also
will,
program
no.
is also using
Dr.
AI
Urvashi,
tool.
I will come to you later on.
Sir, I will just like to complete the list what I mentioned.
Yes.
AI tool is being used for reading line probe assays as well.
Yes.
Tool was developed by
I will come to you next round. Okay, I will come in the next round.
high burden villages. That tool also has been developed, so we know where to focus. Again, that's an AI tool. Thank you.
So, Dr. Shirshendu, my question is that now we have developed, we have come to a point where we can use this artificial intelligence technology for the reading of the chest X-ray by computer-aided detection tool. So my question is, does this mean we are approaching to a point where the artificial intelligence can try a chest X-ray without a radiologist in the loop, and especially in high burden? So what is your opinion on this? Because now there is no need of radiologists for chest X-rays. Please answer to the point.
Thank you, Professor Puri, and thank you, Urvashi, and the organizers for inviting me today. Thanks. I think Dr. Urvashi gave a very good overview of the total, the ecosystem and the landscape in TB management. And I will come from a funder's view where we support innovations to develop tools which are, which clinicians and frontline public health workers can handle with ease and with a high level of degree of sensitivity and specificity. That is what, as a funder, we aim to support innovation for. And your first part of is, can AI replace clinicians? Personally speaking, I will say no at that level. But AI can, as a perspective, AI can become a strong tool for triaging TB at the frontline levels. From a funding and systems perspective, we are no longer we should debate whether AI can match radiologists in detecting TB or chest X-rays. The evidence is increasingly in favor that it can, particularly for triage cases, it should be there. There is a high burden disease, as the high burden areas where Dr. Urvashi just mentioned, and low burden areas. So I think the more important question now is how to responsibly deploy these tools in these high burden areas at a scale with public health systems. In high burden and low resource settings, and that also we should remember, low resource settings, AI offers a powerful, what you call opportunity to democratize access to quality screening. That is in low resource setting, which is where in India and a couple of places we are there. AI offers a powerful opportunity. We don't undermine that, and it democratizes, detection at a level where it can be triaged, and then expand the reach for the sensitive or specific cases to a radiological expert at the next level. However, we don't plan, or the AI should not plan to remove clinicians from the loop at all, but to enable a tired and a care model where AI handles high volume screening and flags cases for human review when needed. I think that is the main aim. AI should, from, as Madam also said, 94% sensitivity and NIAT is 86% sensitivity. There has been some leakage and gaps. So we need to look at that also to see how AI handles it. From an investment standpoint, focus needs to shift from building solutions that are deeply embedded in the national programs, national programs can take up. Innovations can be there, proof of concept can be there. But if the proof of concept is not strongly validated with AI tools and algorithms, and not can be absorbed into the national programs, as Madam said, this doesn't means anything for the country as a large. So this means that investing in large, diverse Indian data sets will be very important to improve robustness, enabling deployment of last mile settings, and supporting continuous validation of the process at a regular. Data needs to be upgraded, refined, and critically clarified in certain levels that we can improve this. So at Vadhwani, we are thinking of creating a national innovation platform, where clinicians, basic researchers, startups, all get together to interact with each other in a regular way.
So,
Change
Dr.
data.
Mukherjee, sorry to interrupt. So you mean that these tools will augment the radiologist capability rather than replacing them? So, and help the program for better performance. So now I am coming to the next question. And my next question is to Dr. Mayank Mittal, and this is for the benefit of all the viewers, that what is AI algorithms? What are the different algorithms which are available for the detection of the computer-aided detection of the chest X-rays, and how they perform, and which algorithms are being used in the NTEP? So Dr. Mayank Mittal.
Yeah, thank you, sir. So first of all, I would like to thank, and Dr. Urvashi ma'am is there. She has already explicitly explained most of the things. But just I would like to reiterate that there are several algorithms available. One of them is from Deep Tech only, which is Deep Tech. Other is from Cure AI. And one which is being used under NTP, which is actually Deep CXR, which is developed by Institute of Plasma Research, Department of Atomic Energy and DHR. And I would like to say that this has already been deployed across 700 mobile handheld X-ray across India. This is a recent data which I am sharing. and soon they will be also launching with their offline module also. So sometimes when there is a difficulty in connecting to the remote sites, so it becomes easier for that for data to transfer. So more or less, I would say like Cure AI and even our deep tech, they already they all have a match with the WHO TPP criteria. But nonetheless, all of them have contributed in the AI-based detection. As Urvashi ma'am told, this is basically a screening tool. But most importantly, it should be used as a screening tool, and the confirmation should be done by nucleic acid tests, which are available with us with the help of NAT and TrueNet. So this is sir, from my side on these AI-enabled X-ray tool.
That is true, Doctor. You have said that TPP. So what is TPP, WHO? TPP?
It is basically set the target product profile with a certain guidelines given by WHO. So there is a certain amount of specificity and sensitivity given. When this minimum criteria is matched, then this is considered as operatable in the setting. So all these techniques have these already matched this, and WHO has already mentioned these techniques as that can be used for the screening tools.
So they have some yardstick that they say that the sensitivity should be
correct. So sensitivity and
specificity should be 70%.
Yeah, should be around sensitivity should be around 90 to 95%, and specificity should be around 65 to 80%.
So that we should not miss the cases.
Correct.
And diagnose the cases. There are some tools which can differentiate that they are highly tuberculosis. Some say that they are susceptible of tuberculosis. Some says that they are normal, and then there are some tools which are says that the X-ray is normal or it is abnormal, so that the normal can be go home and the abnormal can be further seen by the patient. So this is a very helpful technology which will help us to screen the large number of the patient, and means it will be a triage that is there, and the abnormal X-rays has to be confirmed by the microbiological confirmation. So this is a good technology which is being used in the program. So now my next question is that given the challenges of
Dr. Puri, can I
traditional
come
symptoms
here?
here.
Dr. Puri, I'd like to just say something.
Yes, Dr.
I
Urvashi.
think what is being discussed is very valid, but I'd just like to add, since this is a screening method, it's just a triage method.
Yes.
It will just pick, possible TB cases. So if we start confirming TB using an X-ray, then we are going back 40 years. So though the AI tool, they work on several data sets, they come up with, a very valid diagnosis, but to use an X-ray for diagnosing TB will be incorrect. Then we're going pre-RNTCP era.
Yes.
So
that is what we have told, that the AI tool will suggest that it is a suspected or the X-ray is normal, abnormal, or highly suggestive of tuberculosis. And in all those cases, it has to be confirmed.
We believe any abnormal shadow should be subjected to a NAT.
Yes.
Because we would like to treat anybody who's actually NAT positive, who has the disease, and also, even asymptomatic individuals, if they have the disease, they ought to be treated, because possibly we are picking them early. If we leave them untreated now, they could progress to a worse illness later, which due to a comorbid condition will be difficult to deal with. So that is one clear message I wanted to give, that we should offer NAT to all abnormal shadows, and not only TB, the shadows in some programs, like you very beautifully said, differentiate TB from non-TB. X-ray should be used for what it is recommended to be used for. Confirmation has to be using a confirmation technique.
That is very good.
Yeah, thank you.
So my next question is regarding the confirmation of these chest X-ray by examination, microbiological confirmation. As Dr. Urvashi has said, the NAT. NAT is a test which has to be conducted with a specialized machine which should be available everywhere. But in the though we have 6,000 centers, more than 6,000 centers in the country in the public domain where this is available. But sometimes there are some operational problems. We have to look for other methods of confirmation. And one of our oldest method of confirmation is the sputum microscopy. My question is, can we add something on the by using the artificial intelligence, that we can use the sputum microscopy using some artificial intelligence method? So I asked this question to Dr. Narayan Rao, whether he has some any idea or any innovation that he can use the sputum microscopy, or somebody has used it and tried.
Yeah, thank you, Dr. Puli. I mean, I'm not an expert in the sputum microscopy, but no, I'm actually more come with the AI background and the acoustics background.
Okay.
But in general, I can definitely say that, if there is a way to digitize the microscope image, and
I will tell you, Dr. Narayan, what is sputum microscopy, in which we take the sputum and we stain the sputum with certain special stains, and then see the under the microscope the bacilli, and bacilli are red color.
Correct.
So can we use some technology that we can take the images, and the AI can read these images and can diagnose that it is a TB?
Yeah, definitely the answer is yes. If there is a pattern in understanding the presence of the bacteria, then definitely those images can be fed to artificial intelligence, including, I mean, something like a deep learning techniques like CNN and all can definitely be used to train on those images. And once they are trained, of course, when we are training, we need to make sure that we are actually collecting data from various settings, demographics and so on, kind of a thing, including different environments. Once we properly do that, I think the technology is capable of really helping in detecting the bacteria at a scale which is generally not possible with the human resources. So obviously, as earlier people mentioned, we are not replacing here the clinician or the technician, but we are actually aiding them in making their job more effective.
Yes, this sputum microscopic is a very their sensitivity is very poor because of the variation in the skills of the technicians.
Exactly.
A very good trained skilled technician is required. So that's why we are shifting from the sputum microscopic to the CBNet. But as you have said, that this is an area which can be explored, and it is an innovative area.
Exactly.
And few of the studies has been done, and one of this has been published recently in the December 2025 issue of the Indian Journal of Tuberculosis, and they have used this technique. Dr. Mike, you like to add something in this, because I think you are raising the hand.
Yeah, yes, sir. So I think whatever you are saying is very correct, sir. There are already techniques available. So where instead of doing the manual reading, there is an automatic camera which is fixed on over the slide, and we can very visibly see on the screen. So just it makes the counting of the bacilli, whether it is a scanty or 1+ or 2+ or 3+. And same time, so algorithm can be built up with the preset of, like, I'm not an expert in AI, but just maybe a machine learning tool that can be developed so that the microscopy becomes easier and more effective. So in some cases where we may lose, where the bacilli load is very low or scanty, that can be catch up when we are using this AI-enabled microscopy tools.
So,
Dr. Puri, I'd like to add
yes,
that,
Dr. Urvashi, I want your opinion in this. This is your domain.
Yeah. So, Doctor, the point being that the sensitivity of a microscopy will continue to remain low if we compare it to NAT, because the very technique per se has its flaws, in the sense the limit of detection is much less in smear microscopy as compared to NAT. Also, you mentioned 6,000 NAT. Let me just give you the updated information. Till December 2025, we had close to 10,000 NAT systems across the country. And you're probably aware, I'm not sure if all attendees are aware, we were able to validate an Indian indigenous technology with support from ICMR in a multi-centric study, AIMS, NITRD, NIRT, and JALMA, which led to the TrueNAT, coming to the fore and supporting the program in such a big way. Of the 10,000, close to 8,500 are TrueNAT systems. Close to 1,700 are gene expert systems. My point being, we do not have to depend on a company from overseas in case, the supplies are affected in war condition and pandemic conditions. We have our own indigenous technology, which is doing well. And that is how the strength of the program is well. And frankly, during the TB Mukt Bharat Abhiyan, our effort was to move away from microscopy, focus more on NAT, and we were able to move from earlier we used to do 30% NAT of all the tests done. During the TB Mukt Bharat Abhiyan 1, that is what we rolled out last year, 24th December, we were able to move to close to 70% of these tests were now NAT. And in the TB Mukt Bharat Abhiyan 2, we are hoping that we will use NAT in 100% at the baseline because it in addition offers us detection of rifampicin resistance, which is important to decide the treatment regimen. So that is how the program is progressing. With the self-reliance, the country is progressing well, and we want to keep microscopy for follow-up of the patients on treatment because the NAT can remain positive during treatment, where microscopy will pick up only if there are viable bacteria being shed by the patient. So that is how the program is moving. Thank you.
Sir,
Sir,
can
you
you
are muted. Unmute.
Yes. Sir, can you unmute yourself, Dr. Puri? You need to unmute, sir.
It get done. So we thank you, Dr. Urvashi. This research is still required for the artificial intelligence for the further producing the tests which are very economical, which are easily done, and which can be done at the periphery using the artificial intelligence, and the innovations can be done. And we can do these innovation in our country, and we should not depend on the other country on these things. Now, one thing is very clear, the X-ray has come up very far away in the artificial intelligence, but there are certain challenges to deploy these X-rays. So I will ask Dr. Amit Kharate that what are the real life deployment challenges for using the artificial intelligence based chest X-ray screening, and what are the key barriers, and how can we address them to ensure effective rollout and impact our TB program. Though something has been said by Dr. Mukherjee also on these issues, but I like Dr. Kharate to say few words and give his experience because he has done work in Nagpur and using these X-rays.
Right. So thank you, sir, for this opportunity, and thanks for this question. I think I've heard the earlier speakers and very relevant discussions around the use of the solution as a triage tool. In terms of implementing chest X-ray AI at ground level in the field, we have been working in multiple states, more than 500 plus deployments with multiple handheld manufacturers, portable digital X-ray, CR systems, DR systems. I think every hospital workflow is very unique. And what we realize is that whether it's an imaging clinic on mobile or a backpack X-ray, deployment for chest X-ray AI is not very challenging, and I'll explain the reason why. Radiology is more or less very homogenized in terms of the imaging technology. We all use DICOM 3 standards, so that's a standard way of communication for any approved X-ray machine, which is CDSCO or regulatory approved machine. As a result, these images which come out of these machines and the pathway to do a handshake for these machines are very, very well kind of standardized. So connecting X-ray machines, whether online or offline, is not a problem at all. The challenges primarily come in terms of accessibility of hardware. So most of these solutions will be sitting next to an X-ray machine in terms of a laptop or in terms of a device. So there have been challenges in terms of procurement of these devices or handling or maintenance of these devices. So apart from this, we don't face much challenges. There could be two ways of deploying this. One is a cloud version and the other is offline. What we are seeing is majority of the system works in an offline format because these machines are in the field or in hospitals where sometimes they don't even get access to the networks. And then later on, these outputs are used or also synced with the online system. So that these two different mechanisms. And the key advantage of such offline systems are that as and when these machines get access to internet, that is cloud, it could even be a 4G or a 5G network, it can sync data to a cloud platform. Now, the advantage of doing that allows you to also have that review by radiologists. So that's a very important perspective, where the normal abnormal segregation is one journey that the AI product does. Second is detecting TB, and the third means in terms of a presumptive TB suspect. And in terms of the third thing is these multiple other lung pathologies that a AI can detect. So most of the AI solutions which are currently deployed in India and even beyond can do up to 30 plus lung conditions. So it could detect lung nodules, pneumonias, or some things like that. So all these pathways could also be regularized. And that's where the role of the radiologist comes in, where the radiologist can look at the X-ray and give a final confirmation, and on top of it also recommend further tests, or also look for other lung pathologies which can be seen. So that's how most of these workflows are done, and they are pretty much standardized. Except for the hardware, typically we don't face much issues because all these machines are DICOM standard 3 and above.
So what about these clearance? You may require some clearance from the radiological associations or other authorities for whenever you are developing any artificial tool and incorporate it into the chest X-ray machine. Is there any issue?
Absolutely.
That?
Absolutely. This is a very relevant question, sir, and very valid. I think we have been now, this will be the 10th year of our journey for the chest X-ray AI. And it's a very long journey in terms of the regulatory clearance. I think the key clearance is that what we have to look for is the regulatory clearance for the country where the solution is getting deployed, and also globally. So it goes hand in hand, because regulatory bodies always look for other regulatory clearance. For example, if we apply for a particular regulatory clearance in a nation, then other regulatory clearances, what is already been achieved, will always be a strength in that regulatory journey. So from us, we started with the US FDA first. Then we moved for the CE, which is the class 2B for adult and pediatric chest, for TB and pneumonia.
Now, what about the Indians regulations? Because when we develop a new drug, we have to do certain clinical trials and all these things, and then we can go to drug controller. Similarly, these things may be required clearance.
Absolutely. Then I think the third is the CDSCO, because that's a very important clearance. And then also there is certification through the IIPH, Indian Institute of Public Health. So they also do their independent validation. And of course, the Indian Council of Medical Research, with whom we have done certain pilots in certain districts as well. So it's a journey. And of course, apart from that, the WHO study. So we went through the WHO study, and as discussed, the TPP, which is 90/70. So we exceeded that as well. So that is also a part of our study. And these all results are also audited by third-party organizations in terms of the which are neutral to all these separate vendors, and these results are also published in various journals as well. So there are stages. WHO is validation, which is through these agencies, or the ICMR, the IIPH, the US FDA, CE, CDSCO. So this is a continuous process of evolution. This goes hand in hand with other certifications, which could be ISOs, also the ISO 13485 or ISO 27001. Then your security clearance in terms of the SOC 2 clearance, which will be required for your platform. And even your platform needs to be US FDA, CE, and CDSCO cleared. And on top of it is the ABA certification, so that you are completely enabled, so that you can also enable this entire information as secondary captures and other evidences into the Nikshay portal. So that's an entire end-to-end journey. And also it requires the patient registration portal also. So certain sites will also require patient registration, where vulnerability or comorbidities and other details can also be captured. So it is no longer just the AI, the entire workflow, patient registration, the AI, along with the AI, offline, online mode, the platform for handling all this data, sharing this data through a compliant platform, ABA integrated or certified into Nikshay, and then monitoring this and comparing the AI output.
So there are a lot of regulations you have to fulfill. Okay.
100%.
So, okay, now we move to the drug resistance, because in the drug resistance, we do the molecular testing. But the another thing which is coming is the whole gene sequencing. So I will ask Professor Urvashi that now the AI tools are being used to predict the drug resistance directly from the whole gene sequencing data. Is Dr. Urvashi there?
I am here, Dr. Puri.
So potentially bypassing the traditional culture DST. So how confident should a clinician be in AI generated resistance profile? If he is getting a report which is AI generated by using the whole gene sequencing, then how confidence one should be there to treat the patient?
So you see, the whole genome sequencing is a technology which doesn't really offer a lot of advantage to all patients. So basically what I'm trying to say is, to do a whole genome sequence, we need a lot of DNA, meaning only smear positive patients. And that too, so the first point I'm trying to make is, this whole genome sequencing is not a solution for all patients. Number two, what I'm trying to say is, phenotypic, that is a culture-based DST, remains the gold standard.
Okay.
Only the whole genome sequencing can help us in, quickening the result if the DNA is good enough. So if there is a patient who is smear positive and you want to know drug resistance to all possible drugs in a quick manner, and money doesn't matter to you, because whole genome sequencing involves close to, in Indian rupees, each sample involves 15,000 to 16,000 rupees per sample. What we rolled out in the program was targeted NGS, targeted next generation sequencing, where we do not sequence the whole genome, but we only sequence the genes of interest that are known to be responsible for drug resistance. For example, in rifampicin, we know RPOB, the mutations in RPOB will be responsible for resistance in 95% of the cases. Similarly, for all other drugs, we know the mutations which are, more frequent. So detecting those mutations can help us, diagnose with confidence. And the most important part here is, targeted NGS costs much less. Per patient, we can spend about, 3,000, 4,000 rupees, and we will know the drug resistance to the drugs that we are wanting to use for this patient. So I hope the message is getting through. We need not talk about only whole genome sequencing. Sequencing can be helpful, but only when a certain mutation is definitely associated with resistance. So, for example, if I bring in the example of fluoroquinolones or INH for that matter, we are aware of mutations responsible for resistance to 80% of the strains we will be able to define. For the rest, 20%, we will not be able to say whether these patients have or do not have resistance. So you will anyway be misguided. So the crux is the available knowledge. If we have the knowledge of resistance mutations, we can very well use the genotypic DST, that is targeted NGS, or if somebody wants to spend more money, he can do whole genome sequencing. In fact, just to update you, while you've given me the opportunity, under the program, we were able to roll out, I pushed for, globally the first time. No other country is doing it, but in our country, we have trained 43 labs to do phenotypic DST for pretomanid and bedaquiline. In addition, the targeted NGS, 5 centers of excellence for MDR-TB are currently doing targeted NGS for all MDR-TB patients. This will be scaled up soon, and we'll have more labs trained in this. I hope that satisfies your query.
So sorry to interrupt. We're totally running behind, out of time. Yes. So you need to unmute. So you need to unmute, Dr.
So, Mike, to conclude, Dr. Urvashi, regarding the drug resistance, that the phenotypic DST should be used to confirm the resistant pattern and monitor the patient according to the treatment response. And the whole gene sequencing is basically for the research to look for the new genes which are probably the resistance. Now we come to the another, how much time we are left?
So we have totally run out of time.
So should I wrap these? or should I continue?
So I think we need to wrap because
So in the
another
last,
two
I will
questions
ask.
also we need to take. Yes.
So I will ask only one question from all the panelists. The same question will be put from all the panelists, and they have to answer in one line. And that question is very simple question. So first I asked Dr. Narayan Rao that if you had to identify one AI application, this is the same question for everyone. If you have to identify one AI application in TB that if probably resourced and implemented over the next 5 years could have the greatest impact on TB control in India, what would it be? Dr. Narayan.
So my answer is a unified AI layer which uses cough audio, chest X-ray, and basic metadata to identify TB risk early.
So AI for chest X-ray. Okay, thank you.
Cough and metadata.
Okay, and okay, cough also. Dr. Amit Kharate. Dr. Amit.
Yes, I completely agree. I think all these innovations could be on one of the platforms, and through this, basically,
Only one AI you should tell me which.
The chest X-ray AI, certainly, because I think it's
and
the
Dr. Mayank Mittal.
Sir, again, I would totally agree, and I think that this AI-based chest X-rays more needs to be developed, and that will be, I think, help us in screening.
And Dr. Shri Shandhu.
Sir, a national AI-powered TB stack for X-ray.
And lastly, from our Dr. Urvashi, who is the head and the program manager, has a vast experience as a program manager. Which is the one AI which we should use?
Sir, I would say X-rays because, what we have moved on is from symptomatic to asymptomatic TB because we want to pick active TB, subclinical TB, all of it. And it has the capability to reach the population, reach the common man, rather than a patient having to reach the hospital. So I would say AI to read all abnormal chest X-rays, and we can, scale it up to reach all our community. From vulnerables, we'll soon move to the population at large, so we can break the chains of transmission in the community and eliminate TB. That is my take.
Thank you. Thank you so much. So as we wrap up, let us revisit what we needs to go right for AI to make a massive impact of TB control. Though it is in the chest X-ray, what it should be a validated AI tool for diverse Indian population. It should be able to be integrated with the NTP workflow, and it should have the timely approval of the health authorities, and it should be having good training facilities for the healthcare worker. If we put all these in the place, only then the AI-powered solution can significantly boost the TB case detection and accelerate the Indian TB elimination efforts and bridge the gaps in screening and care, especially in rural area where the resources are limited. Thank you very much. The National TB program is already exploring these AI solutions, as Professor Urvashi and Professor and Dr. Mittal has already enumerated certain studies which has been done. And AI can be a game changer for Indian TB fight if it is used with the right approach. Thank you, you panelists, and thank you, the audience, for joining this crucial discussion. Thank you very much.
Thanks, everyone. Thank you. Bye-bye.
Thank you. Thank you, Dr. Puri. Thank you, all the panel members. We're extremely grateful to each of you for taking out the time to join us and for highlighting the need to move from awareness to action as we work towards the TB elimination goals of 2030, from gaps to challenges to AI-driven innovations, turning vaccine trials into reality and much needed research. Every discussion today has been a step up the ladder towards achieving these goals. With this, of course, before I close the webinar, there is a question for a few panelists. I think Dr. Rao, there's a question for Dr. Rao. How can your AI tool help in screening TB cases, and how can we scale these? Dr. Rao, can you please take up the question? Has Dr. Rao left? Mr. Amit, would you like to take this given your tech background, sir, would you like to take up the question as well?
So, ma'am, what exactly is the question? If you can just repeat it again.
How can your AI tool help in screening TB cases, and how can we actually scale these up?
Right. Yes, ma'am, this was covered extensively by the earlier participants. So basically, it's for triaging. It's a triage solution. We basically will be able to separate cases into normal and abnormal. And abnormal, wherever there is a high kind of suspicion of TB, in those cases will be shown by a heat map or outline view or a bounding box with a percentage probability score. So those patients basically are by the health worker will need to be then basically moved up the ladder in terms of further sputum analysis in those particular cases. So that's one of the most standard use case that we recommend for the screening workflow. And I think that's the only use case. On top of it, you can add probably the radiologist review for all cases which are abnormal. So the radiologist can either do an audit of the 10%, 15% normal, or all the abnormal, or certain percentage of abnormal. So initially, when the AI is coming into the workflow, into the community, the workflow should be that there should be an audit by an expert. And as the confidence level increases, this audit can then reduce to a certain subset of cases, but that audit should happen. So that way it enters the workflow very smoothly. And there is also kind of some kind of a comparison, and those matrices can always be worked upon. And this also needs to be compared with the final sputum results. And there should be a collaboration between the AI vendor, between the researchers on site, sputum results. So then these outputs can be shared with them, and then appropriate threshold tuning or directions in the way we need to change the sensitivity or specificity could be taken. So that's a very critical step in successful implementation of AI.
Thank you. And there's one more comment specifically related to data privacy breaches and patient privacy concerns. It's not a question, but a concern which someone has raised. Misuse of these solutions, over-reliance on AI without clinical validation is what they're pointing out. Would any one of you want to say something to that?
Right. I can take a first kind of a step in answering this, and I think Dr. Puri sir can also add. But just to give you an overview, these solutions created by any of these AI vendors, including us, they are fully offline solutions. So the data does not leave the hospital or the imaging center or the van. So this data completely is, the solution is an offline center. The screening or the triage results will be available within 30 seconds to a minute, and it stays on that device. And if the solution is a cloud solution, then it is always going to be on a government cloud portal. So wherever the portal which is decided by the organizations, we basically can deploy the entire solution. The solution is entirely cloud agnostic. It could be a government portal or a government cloud, or it could be a hybrid, or it could be a completely private cloud. So whatever it is, it could be deployed on that. So both these options exist. So in that particular aspect, there is 100% kind of data sovereignty exists with the institution or the imaging site from where the data is getting analyzed. I hope I kind of answer that particular question.
Yes, absolutely. Thank you. So, okay. So, anybody wants to answer that, add to that, or we can close? Yeah.
I think the concern about the data cannot be shared with others. That is the standard for all these data now. That they give the assurance to the person that this data is used for them only. It is already inbuilt there. So I think this is also built in these AI programs when they are launching these AI programs by the concerned manufacturers. And you cannot share these data unless and until the consent of the person is given. It is
sure.
like
Thank
that.
you. Thank you. Thank you so much, everyone. With this, we bring today's webinar to a close, and we will continue to host many such important conversations on critical public health challenges. And we would love to, for you to come forward and partner with us on such initiatives. We have also pinned our email IDs in any case anyone is interested in actually writing to us with or sharing a feedback or some notes. You can actually, we've already pinned the email IDs. would appreciate that and encourage that. Thank you so much, everyone. Thank you so much, everyone, for joining in.